provincial budget on healthcare. Okay. The more well-off provinces such as Alberta, Newfoundland, of course, getting richer and richer all the time, and BC was surprisingly this figure here. That's when BC was in a bit of a slide. BC was, you all heard of have provinces and have not provinces? You all have? Okay. BC, of course, was a have province most of its life, and all of a sudden became a have not province for about 3 or 4 years, and now back to being a have province. How do we compare? Okay, 2006 data of the OECD. All of our international data on healthcare costs comes from the OECD in Paris. And it's generally considered to be reasonably reliable. It's just that it's 2 or 3 years late before they actually collect it. Alvaro, did you want to?
No.
So 2006 data, 25 selected countries, including those at the top. We were 8th in terms of the percentage of GDP we spent on healthcare. Okay? Just going to the website yesterday to see what the status was. The most recent data is 2007 data. And it's in a PDF file that you can't copy the picture, so you have to buy it. But you can copy the text. We are now 6th in terms of spending between, again, we're in 2007, we were below 11%, well below 11%, and we were 6th. Now we're going to be at 11.2%. So I think when the 2008, 2009 data comes up, I suspect Canada may be higher up in the rankings in terms of what we spend. Glenn?
You know, we toss those numbers around, and you look at it and say, well, that's bad or good. Actually, I don't know how to interpret it. Is there a certain percentage that's bad? Like, is 15 terrible? I don't know. I mean, it's probably good for economies. You look at America, you know, the healthcare is a huge business down there. You know, you can't outsource that work.
Is it a healthier nation?
No. United States? United States ranks below 20s.
Maybe they're not a good example, but you're not getting it. Is there a percentage
No,
that's bad or good?
I don't think, I'm not sure there's an answer to that. Okay. If you look at the OECD data, which is probably the best data, which covers about 40 countries, okay, you can see what the norm is. You can see there's a number of countries below and above the average. The UK, I know, a number of years ago, said that they were spending 6.6, and at the time, Tony Blair said that's not enough. We've got to improve it. So they committed and half raised the expenditure in healthcare to high 8s, to 8.9 or something last time. Okay. The European average is 8.7. Okay. Whether that's right or wrong, you're now into not only economics, you're into the political domain as to how public policy in terms of employment and consider having a million healthcare workers good for public policy, or would you rather have only 800,000? It wouldn't cost too much. It's not a simple question. It's out of my realm, that's for sure.
I think it's not so much how much you spend, but how you spend it. So if you compare countries like Japan, where they have, they spend about the same amount of money, I think, as Canadians do, or similar.
Well, they were known for years and years and years of having a so-called better healthcare system for a lot less money.
Right. So what happens is that they have more doctors per citizen. Right. They have more nursing, more beds available.
Careful. One of the things they also have, it's the characteristic is families look after patients in hospitals.
Right.
Not nurses, families. We have a few nurses, but the expectation in Japan is that the family will come in and feed the patient and look after the patient.
That I'm not sure, but I'm just saying that it's not so much just the crude number. You have to look at compared to a number of performance indicators.
Absolutely, absolutely. With many, many factors. Okay, we're not trying to be simplistic here. Absolutely, with many, many factors involved. Okay, and the Japanese number is creeping up. Why is it creeping up? Because their diet's changing. Exactly, their diet's changing. So, lo and behold, their healthcare costs are going up. Okay, and their chronic disease is going up. And they're attributing a large part of it to diet and lifestyle. Okay, so, regionalization. Probably the most important recent phenomenon in world healthcare. Okay, remember I went back there in the 50s, we had the Hospital Insurance Act, Hospital Insurance Act. Everything in healthcare, from the healthcare system started in Canada in the late 1800s with the original places which were actually hospices kind of places that where people went to die. That was the origins of hospitals in Canada, run by the religious orders. So the healthcare system, post-war, the healthcare system around the Western world just exploded in terms of the growth of healthcare, particularly around building hospitals. Okay. So everything was financed around hospitals, okay, and acute care. Okay. Not primary care or any other kind of care, acute care. That's changed, okay? You see, is that a question or a stretch? You see, is that a question or a stretch?
No.
Oh, it's a stretch, okay. The profile of hospitals, you could say, is from 1200 in 1986 to 2000 in 716, and it's now hard to know exactly how many hospitals we have, because the notion of hospital has changed quite dramatically in the last 5 or 6 years. But it's a lot less than that. So why do you think, what's the sort of major reason, that huge drop in the number of beds and the number of hospitals? Tracy?
People are being sent home more quickly
Why?
now
Why?
to reduce the cost
No.
of their patient stay.
Efficiencies.
No. Bad.
Oh, no question.
Infection issues.
What?
Infection.
No.
Shortage of staff.
No.
I mean, it's to improve from an acute care point of view, it's to improve your throughput. If I can get a patient in and do their surgery the same day, I can do it all
Yeah,
up.
okay, but why can you do the surgery the same day?
Improve technology.
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 Thank you. Thank you. Right? We have technology now. I mean,
You know, in fairness though, it's like from orthopedic standpoint, a total hip implant, if I put two in front of you, not so I see a difference.
Yeah.
It's an absolute change in the philosophy of treatment of patients. Like, morphine and narcotics is radically different, we've been able to lot it, it's not different, it's been a change in pathway. For orthopedics, I think I speak of, we've been able to change our pathways to get patients out quicker. If you tell you, if I told you, what, I'm gonna do your full hip, but you're gonna be in hospital for 10 days, you're gonna go, great. If I tell you, well, you're gonna be for 4 days, get your life in order, then all of a sudden,
Well, 3 days. But there's no doubt that technology, medical technology, is definitely allow us to do things now on an outpatient, same-day basis.
Right.
That we couldn't do in the 80s, okay? I mean, look at the lithotripper technology, right? Lithotripper, which shatters kidney stones.
yeah.
Well, kidney operations take out a stone 10 to 12 days after to recover. Go in the morning, get blasted by the machine, they're out the same day. Okay, so those kinds of technologies, right?
I still think,
Keyhole surgery, all that.
But I think what Glenn's saying, I think the
Well,
optimization,
yeah. And Glenn's in an area too where
Yeah.
perhaps the technology in orthopedics hasn't been quite as dramatic. Yeah.
We're also doing a lot more, like even workup as outpatients.
Yeah.
People
Yeah.
that used to have to come in the night before for pre-op assessment are getting it all done in outpatient clinics
Before they-
and then coming in the day of and getting their surgery. You're not
Exactly.
sucking up beds. Beds are too expensive.
Yeah,
Yeah,
exactly.
I have to agree with my fellow clinicians here. Honestly, technology plays a very little role in that. It's more the culture change and things that we used to admit people to the hospital for, we're managing at home with the same medications we used to
Okay.
manage them
Okay.
in hospital. You would get admitted 10 years ago for IV antibiotics. Now you get IV antibiotics at home, same antibiotics. It's just you're getting them in a different place.
It's a very fast, I wish more time we should put that as a project. It's a fascinating project. At the back, what's your name again?
Mohammed.
Mohammed, right.
Yeah. Well, actually, I'm just kind of interested knowing if there's more statistics after the year 2000 and if the bed numbers have stabilized a little bit. Because what I've seen when I work right now, even with the latest technology, even reducing the surgery with time and all that, they still have a big initiative to send people home. You want to discharge more people home, and
Yeah, no, I agree.
you don't want to even send them to long-term care facilities.
Yeah. I asked for some data, and it's much harder now to get hospital-based data, okay? Much harder. And I asked CHI last year for more recent data, and they couldn't give me any more recent data. Because we've changed the way we organize healthcare. So I would speculate that perhaps we've stabilized in terms of beds, but I would speculate we're possibly still going down. Interesting point about the dogs here, because my simple understanding is one of the big impacts has been the things that we're able to do medically now that require post-procedural stay is one of the major reasons why we have less beds.
Unfortunately,
Plus reducing costs.
unfortunately, there's no need of the assessment of the beds. Is it because the different types actually need this hospital beds number there, regular blocks. Sometimes that is we can't have.
The need's infinite. John?
Yeah, I'm not a clinician, but I know that since there is the introduction of the laparoscopic surgery,
Yeah, exactly.
the length of stay has dramatically reduced. So it's, I don't know what about the other clinician, why they.
Combination of everything.
Okay, rebuttal?
As a surgeon who does laparoscopic surgery, it makes no difference. We noticed that the early studies on laparoscopic, I'm a general surgeon, I do bowel surgery, so laparoscopic bowel surgery, they first noticed that, oh, these patients do great, they go home 2 days earlier. And then we started treating the patients who were operating on open the same way, and they go home in the same amount of time. It's all a changing philosophy of care for these patients. It's not if you ask a minimally invasive surgeon, they won't agree with anything that I'm saying, but as someone who does both and sees both, it is the technology no doubt helps to some
Okay.
degree, but a lot of it is just the philosophy of care.
Now, who's driving that philosophical change?
Well, it's partly the people who don't necessarily do the minimally invasive surgery are saying, well, I can do the same thing as you can, my patient can do just as well as yours can. And in part, it's the residents coming up through it, seeing both sides and realizing that there are.
There's also like,
Okay, one more point and we'll go
yeah,
on.
sorry, there's a lot of incentives, like from at least in Ontario to, like, you get more money, the hospital gets more money if you treat people quickly and get them home. And that's changed a lot of.
And that's because of
health-
radiology.
Of course. But, so when we get, for example, in the emergency department, I see a patient, if I can send them home within 6 hours, the hospital gets a certain bonus. I know that if I ask for a bed, that they're gonna linger around in the emergency room for 24 hours and we're gonna get penalized for that. So there's every effort to get the people home as much as we can because the hospital benefits that way.
And there's an increased use of imaging for that very reason.
Yeah.
It's
I
a,
don't know if you agree,
Okay.
but imaging gives the clinicians a sense of confidence that,
Yeah.
you know, at least can't
Yeah.
see.
Yeah, that's right. Yeah, see something.
Which, and imaging's changed immensely in the last 15 years.
Okay, this just shows you how things have changed over the years. I imagine these graphs, this graph just goes continuing going up. And this is the daycare graph, okay? Doing procedures the same day, okay? You see how that's grown in the last 20 years, and in terms of the number of beds where people have to stay overnight in the hospital. Okay, in the 80s, across Canada concerns, not across Canada, around the world concerns about the growing cost of healthcare. We went through a number of studies in Canada. Virtually every province went through a study. And I was just thinking as I was looking at this last night, we were due for another big study. We haven't had a big study in Canada since the Romano Commission in 2002. So it was during that period where we entered the area of regionalization in Canada. Okay? Now before regionalization, so before the 90s, early 90s, we had hospitals, we had community health agencies of various types and forms, home care programs, long-term care and continuing care facilities, public health programs, mental health programs. They're all independent, autonomous organizations doing their thing by themselves. Okay? So they all had their own chief executive. They all had their own boards. They all had their own directors of finance, and so on. They're all running independent organizations. Post-regionalization, and this happened